Good morning, everybody. I am Dr. Nitin Joshi, Professor in Urology with teaching experience of 25 years, working as consultant neurosurgeon in Panvel. Today we will discuss the question Febuxostat. Febuxostat is a xanthine oxidase inhibitor group of drug and it is used to treat hyperuricemia and hence hyperuricemic hyperuricosuria and gouty diastasis. In human being, uric acid is the end product of purine catabolism, that is catabolism of alanine and guanine, and is formed in liver. In case of catabolism of adenine, that is adenine and its nucleoside adenosine and its nucleotide adenosine monophosphate, initially they undergo deamination to form an intermediate compound called hypoxanthine. This intermediate compound hypoxanthine is then further degraded by again enzyme xanthine oxidase to form xanthine, and this xanthine is the final common degradation product. While in case of the guanine catabolism, it is only guanine which undergoes deamination but without forming the hypoxanthine compound, which is an intermediate compound. And in catabolism, in case of guanine, by deamination, it's get converted into xanthine, which is the common final degradation product. So in case of adenine and guanine, ultimately the xanthine is the final common degradation product. However, this xanthine has to be oxidized again by xanthine oxidase enzyme to form the uric acid in liver. So in case of the enzymes inhibitor, that is xanthine oxidase inhibitor group of drugs like allopurinol or febuxostat, they are responsible for inhibiting this enzyme xanthine oxidase. So in case of the adenine catabolism, they prevent the formation of xanthine from hypoxanthine, and the common degradation product, that is xanthine, is not oxidized, which is the common degradation product xanthine is also oxidized by xanthine oxidase to form uric acid. So overall effect of these drugs, that is allopurinol and febuxostat, is no formation of hypoxanthine in the adenine catabolism. This hypoxanthine is not converted into xanthine, and xanthine, which is the end product of adenine and guanine catabolism, is not oxidized to uric acid. Thus there is decreased uric acid synthesis, hence decreased uric acid level of blood, thus correcting hyperuricemia and thus correcting hyperuricemic hyperuricosuria. Now what are the causes of hyperuricemia? The first cause is increased intake of purines, particularly non-vegetarian diet like the shellfish, liver. Second, that is the anabolism is abnormal. That is, in case of purine anabolism, if there are congenital defects, that is congenital deficiency which is partial or complete of HPRT enzyme, that is enzyme hypoxanthine guanine phosphoribosylate transferase, which is responsible for recycling, or if intracellular hyperactivity of phosphoribosylate transferase synthetase, this will result into increased purine anabolism and hence increased purine catabolism, causing increased uric acid level of blood. While secondary hyperuricemia is where there is increased nucleic acid catabolism or turnover, which is seen in case of increased tissue turnover or tissue catabolism like myeloproliferative disorder, lymphoproliferative disorder, multiple myeloma, hemoglobinopathies, thalassemia major, pernicious anemia, various malignancies, and their treatment, that is radiotherapy and chemotherapy. Hyperuricemia results into hyperuricosuria. Hyperuricosuria is defined as the process of excretion of more than 600 mg of uric acid in urine in 24 hours. This hyperuricosuria can be of three types, and namely it is hyperuricemic hyperuricosuria, normouricemic hyperuricosuria, and hypouricemic hyperuricosuria. Xanthine oxidase inhibitor group of drugs are able to correct hyperuricemic hyperuricosuria and normouricemic hyperuricosuria, but the xanthine group of drugs is unable to correct the hypouricemic hyperuricosuria. Hypouricemic hyperuricosuria is seen in patients who show the mutation in the gene of uric acid transporter protein. This uric transporter protein is seen in the luminal cells of the proximal converted tubule, and this uric acid transporter is responsible for reabsorption of 90% of monosodium urate present in the glomerular filtrate in proximal convoluted tubule. Defect in their function results into defective absorption of 90% of monosodium urate from the glomerular filtrate in proximal convoluted tubule, causing hyperuricosuria. Also, some of these patients they show presence of organic anion transporter. This organic anion transporter, which is present along the basolateral membranes of proximal converted tubule, is responsible for secretion of the monosodium urate from peritubular capillaries into the lumen of proximal converted tubule, causing excessive secretion and hence excretion of monosodium urate. Thus, these patients show increased excretion of uric acid as compared to the filtered level of the uric acid in filtrate. Continuous excretion of such high level will result into hypouricemic hyperuricosuria. Whatever is the type of hyperuricosuria, hyperuricosuria is proved etiological factor in pathogenesis of hyperuricosuric calcium oxalate stone disease and hyperuricosuric uric acid stone disease. However, their pathophysiology is intimately related to the urine pH. pKa for uric acid is the ionization constant for uric acid, and in the body, that is at body temperature of 37 degree, it is 5.35, while outside the body temperature it is 5.5. In case of the patient with the hyperuricosuria, if the pH of the patient urine pH is less than 5.5, then they are responsible for formation of pure uric acid stone, while in patients who are having hyperuricosuria but urine pH is more than 5.5, then these patients are responsible for formation of hyperuricosuric calcium oxalate variety of the stone. This is because in case of distal nephron, that is the distal part of distal converted tubule, collecting tubule and collecting duct, the maximum acidification and concentration of urine takes place. Due to concentration of urine and in presence of hyperuricosuria, naturally the concentration of both, that is uric acid and monosodium urate in tubular fluid, increases. When the urine pH is less than 5.5, then because of this low pH, there is more and more conversion of the monosodium urate into uric acid. Already the urine is concentrated and the patient is having hyperuricosuria, and more conversion of monosodium urate into uric acid. Plus, in case of the acidic pH, the solubility of uric acid goes on decreasing. This results into supersaturation of tubular fluid with pure uric acid, causing ultimately the spontaneous precipitation due to supersaturation, and this is homogeneous nucleation. And then the nucleation progresses to the formation of pure uric acid stone disease. In case of the hyperuricosuric calcium oxalate stone disease, the only difference is the pH of the tubular fluid is more than 5.5, and this patient also show increased excretion of sodium and calcium along with hyperuricosuria. So in this patient, because of concentration of the urine and hyperuricosuria, there is already more and more monosodium urate, and pH is such that there is more and more conversion of uric acid into monosodium urate. This results into more and more concentration of monosodium urate in the tubular fluid, causing supersaturation of the tubular fluid with the monosodium urate, that is, shifting the tubular fluid to the unstable zone for monosodium urate, causing spontaneous precipitation and nucleation of monosodium urate. And once the monosodium urate is formed, then these hyperuricosuric patient in presence of increased excretion of calcium and sodium, there are two suggested theories, and that is epitaxy and the salting out mechanism responsible for formation of calcium oxalate stone disease. Thus, if we correct hyperuricemia, one corrects hyperuricosuria, and thus one able to prevent and treat the hyperuricosuric calcium oxalate stone disease and hyperuricosuric uric acid stone disease. Allopurinol is also xanthine oxidase inhibitor group of drug, which is also used for the treatment of hyperuricemia and hyperuricosuric stone disease. However, the studies have shown that the Febuxostat is superior to allopurinol. This is because with the Febuxostat, the fall in the uric acid level in blood as well as the fall in uric acid level in the urine is more with Febuxostat or superior with Febuxostat than allopurinol. Second, in case of Febuxostat, the dose is OD, that is 40 mg OD, while in case of allopurinol, it is 3 times a day, that is 100 mg 3 times a day, and the dose depends upon the half-life of the drug. Third, that is the liver dysfunction is common with both allopurinol and Febuxostat, but liver dysfunction in form of raised bilirubin, raised HGOT, raised HGPT is more prevalent with allopurinol than Febuxostat. Also, the allergic response in form of the rash progressing to the Stevens-Johnson syndrome is more common with the allopurinol than Febuxostat. So, Febuxostat is superior than allopurinol. Febuxostat is available in form of 40 mg strength and 80 mg. It is oral drug and normal dose is 40 mg OD. The side effects of Febuxostat or allopurinol is cardiovascular toxicity or cardiovascular events. Second, abdominal discomfort in form of the anorexia, nausea, vomiting, abdominal pain. Liver dysfunction in form of raised HGOT, raised HGPT, raised bilirubin, and so requires regular liver function test monitoring. Then there can be allergic response like rash, pruritus progressing to Stevens-Johnson syndrome. There can be the drug interaction, that is decreased absorption of the drug in presence of antacid, theophylline and allopurinol. The uses of the Febuxostat as well as allopurinol is one in the treatment of hyperuricosuric calcium oxalate stone disease, particularly useful in the prevention of hyperuricosuric calcium oxalate stone disease. Studies have shown that in treatment for the prevention of calcium oxalate stone disease, even potassium citrate is useful. Second, the allopurinol and Febuxostat is useful in case of treatment of hyperuricosuric uric acid stone disease, active treatment as well as prevention. But studies have shown that in case of hyperuricosuric uric acid stone disease, the first line of treatment is alkalinization of urine with potassium citrate. Allopurinol as well as Febuxostat is useful in case of gouty diathesis as well as it is useful in gout. Thank you very much.